Welcome everyone to our third journal club in conjunction with MKRC. I would like to thank Dr. Staudinger and Shelley for helping us put this together. Today, we're excited to announce Mitch Frydenlund. He's going to be presenting an article comparing surgical outcomes in survival in glioblastoma resection with intraoperative MRI utilization. Mitch is a second year at the University of Colorado School of Medicine. He's an inaugural member of Energy, and he's also the co-president of the Neurological Surgery Interest Group at the University of Colorado. Before med school, he earned a bachelor's in art and biochemistry from UC Boulder and a master's degree in law from Northwestern University, Pritzker School of Law. His interests include brain cancer, ultrasound, and healthcare policy. And without further ado, I'll let Mitch get to presenting his article. Thank you.
Thanks, Eddie, for the intro, and Dr. Staudinger and Shelley for putting this on and setting this up. Can everyone hear me all right?
Yes.
Is that good? All right. Let me share my screen here. Having a little trouble earlier, so let's see if it's finally working. 1 second. All right. How's that looking for everyone?
Perfect.
All right. So I can't see anyone on video or the chat or anything like that. So if you have any questions or comments you want to add, feel free to interrupt me and ask. So like Eddie said, here's the title of this presentation. I apologize for the kind of wordy title, but we're going to be looking at the surgical outcomes and survival when we use intraoperative MRI in glioblastoma resection. So I have no disclosures at all related to this. It's also worthwhile noting that the authors of the article we're looking at have no direct financial relationships or disclosures as well. So here is the article we're looking at. It was published in the Journal of Neurosurgery. It was published online in the beginning of October of this year. So it's fairly new, so it should be fun to dig into. So before we do this, I don't know how many people on here are familiar with glioblastoma. I just thought it'd be worthwhile to just briefly go into it so everyone's on the same page. So this is very kind of basic level. Don't worry about all these genetic mutations. This is just to show in glioblastoma, there's two types. You can have a primary glioblastoma that comes right from your precursors. There we go. And then you can also have secondary glioblastoma, which goes from the precursors to the low-grade gliomas, then to the high-grade glioma, which is also known as a glioblastoma, right? So that's all this is showing. And this just provides some information about the mean diagnosis, age of diagnosis, 61 years old. This is the most common glial cell neoplasm in adults. It's infiltrative, so as a result, it's not curable with surgery, but we still perform surgery to debulk the tumor. So to make the diagnosis, it's with MRI and histology. So on the imaging here, this is a T1 weighted MRI. You can tell it's T1. The outer gray matter is gray. The inner white matter is white. You can see this is pre-contrast. We don't see any vascular that's lit up. But we can go around and we can see that clear demarcation between the gray and the white matter all the way around until we end up here in the left temporal lobe. You can kind of make out this hypo-intense disruption. So without any contrast, you can't really tell exactly what's going on, but something's definitely not right. Maybe you can point out a little bit of a horseshoe here, but once we do the contrast, you can definitely see this lights up with the ring-enhancing lesion. It's kind of the buzzword for step one, I suppose. And in the center, you have this hypo-intense central necrosis. So ring-enhancing lesion with hypo-intense central necrosis. And then this edema, you can kind of see as well, this hypo-intense edema surrounding it. Those are the classic features on a T1 weighted MRI with contrast. And then just briefly, the histology. You can see the normal histology over here. The nuclei are fairly large, but when we get over here, you can see the nuclei are fairly small, a lot of nuclei relative to cytoplasm, small and irregular, and here it says palisading. I think it's pseudo-palisading around this central necrosis. So small, kind of tumor-looking surrounding this central necrosis is kind of a hallmark of histology for glioblastoma. And you can also point out these microvascularizations here and here, and that's what's leading to that ring enhancement. And so that's how we diagnose it. Treatment. The current treatment is something called the STEP regime. It's maximal resection of the tumor. This is just a generic view from a microscope of a tumor operation taking place. And then also radiotherapy. This is just a picture of the radiotherapy. You can see the beams focused on the area they're looking at, or they're trying to radiate. And then the chemotherapeutic agent, temozolomide. It's an alkylating agent, and it's really the only chemotherapeutic that has been shown effective in glioblastoma treatment. But even with all this, it's pretty dismal prognosis. Median survival is 15 months. 5-year survival is less than 5%. So yeah, definitely concerning. We're only going to just briefly talk about this IDH wild type versus IDH mutant. These are all the prognostic factors. They were mentioned in the article. They're pretty well understood. But just for a basic understanding, you really just need to know this IDH wild type versus IDH mutant to understand glioblastomas. So again, here, don't worry about all these genetic mutations. What I'm really trying to show here is that this IDH wild type is associated with primary glioblastoma. Right? You see from the progenitors, we go straight down to this primary glioblastoma, IDH wild type, and that is a worse prognosis. And you see 6 months to 2 years. That IDH mutant, that's associated with the secondary glioblastomas, and that has a better overall survival, a better prognosis, mostly because the chemotherapeutic agent is more effective with those in those patients. So I just finished up all the basic information about glioblastoma. Does anyone have any questions or comments they want to add?
Mitchell, I just will add that we can't see your cursor.
Oh, okay. Thank you. Let me see if I can. Let's see, pointer options. How about now?
Perfect.
All right. So sorry about that. So, okay, so if no one has any questions, I guess we will move on. So again, now we're going to get into the study. So here's an intraoperative MRI, kind of the visual. Here's the surgeons, here's the patient, the intraoperative MRI. Hopefully they're going to remove these sharp metal objects before they turn on the magnet, but this is the basic setup. And the purpose of the intraoperative MRI, as you can imagine, is to increase the extent of the resection of the tumor. Right? That's the EOR. You'll see this acronym throughout the presentation. And this isn't necessarily a new kind of technique or therapy or intervention or whatever you want to call it. But the prior use and the prior research has really been limited to low-grade gliomas. I'll just go back to this slide briefly, right? These low-grade gliomas. It hasn't been much evidence for the high-grade gliomas, also known as the glioblastomas, right? And there's a controversy, at this point here, there's a controversy of whether total resection is clinically necessary. So the evidence shows that, yeah, if you take on more tumor, there's an overall increase in survival, right? Statistically significant. But the authors note that there's some studies out there where maybe we do get overall survival, but maybe that's really not clinically relevant. Maybe we don't need to chase down every single last cell. Maybe there's a point where we get rid of enough tumor where we can really get the maximal effect. So this study aims to examine the outcomes when we use the intraoperative MRI in those high-grade glioma, the glioblastoma resections. Right? And before going on to the study design, here's a little bit more information about the intraoperative MRI. Here's another just generic picture of what it looks like. I put this picture here. This is a pathology specimen, and it's pretty obvious the tumor is on this side of the brain, right? You can see there's necrosis here. The basal ganglia should be here. Here's the normal basal ganglia. Basal ganglia is totally disrupted. You can see that this just looks like bad news. Definitely at the edge here, it looks like it'd be tough to delineate where the tumor ends and where normal tissue begins, right? But if taken in the whole context of the brain, you could probably do a pretty good job of finding that edge. But surgery doesn't look like this, right? they're using microscopes, and this is more the view you get, right? So you can imagine how tough that would be to try to get all that tumor out and try to find that line where you end tumor and when you get to normal tissue. Right? So that's the whole purpose of intraoperative MRI. This image, this comes from the study. It was used to show how they calculate the volume of the tumors, but I think it does a good job of showing, just visually, why you want to use it, why you want to use intraoperative MRI. Does anyone have any questions here, comments? All right. And then just a side note, they didn't talk about this in the paper, but it's, maybe important to understand for a complete picture. There are other intraoperative techniques with the same idea of trying to find, try to catch those last bits of tumor, right? So there's this 5-ALA dye, which is swallowed, and then the fluorescein dye, which is IV injected. Both of them find tumor cells by kind of highlighting areas where the blood-brain barrier is broken down. Right, so here, just a quick demonstration, right? You have a tumor, we definitely got to take that out. They presumably take it out and they're thinking, well, I think I'm done. Time to double check. They turn the lights on, they turn on the UV light.
You can stain the brain and see where the blood-brain barrier is broken down. And so you can use that to determine like other methods besides intraoperative MRI.
Right.
Oh, sorry about that.
Oh, no problem. That was a very, very good way to explain it. So yeah, the dye just highlights the broken down blood-brain barrier. So here it's highlighted pink. You definitely got to go after that and get the rest of that tumor. And this just shows what it looks like once you get all the tumor out. That's confirmed by MRI. So now, this little tangent aside, we're going to get back to the study. And this is the design that they used. They did 2 cohorts. They did one called a multi-center, where they used a large database. This is the name of the database. It has 11 or 12 centers contributed patient information. There's over 9,000 patients that had intraoperative MRI and non-intraoperative MRI. And their criteria was this newly diagnosed supratentorial WHO grade or WHO grade 4 glioblastoma. So kind of your bread and butter glioblastoma. The study started in 2008, but they did a retrospective collection from 2008 to 1996 and then prospective from 2008 onward. From that, they got 640 patients. You can see the breakdown of, MRI use versus non-MRI use. And from that, they got what they call general predictors of the extent of resection. And that included things like the year the surgery took place. You can imagine the technology available in 1996 versus 2019 certainly would play a role in the amount of tumor you're able to take out. The patient's age. They use this ASA score, this American Society of Anesthesiologists score. It's kind of like how sick the patient is. That's typically not used. They typically use KPS scores now, but the authors were saying that using the ASA score was more available, so they're just using that as a surrogate, just for the general predictor of how much tumor they'd be able to take out of a patient. And then they also combine this with a MRI analysis cohort. So they just took it from a single author's institution. They didn't specify which institution. And similar criteria, glioblastoma resection cases where they had the pre-op, intra-op, and post-op MRIs available. And they went from 2008 to 2018. They got 286 patients. And from that, this is what makes this study relatively unique compared to the previous studies, is that they looked at these more granular details of what are the features of the tumor on the MRI that will dictate how much tumor they're able to take out. Things like, is it bilateral? Is it next to eloquent structures? Things like that. They also looked at whether the surgeon was planning to take out all the tumor, this gross total resection, or whether the surgeon was planning to take out a subtotal resection. It's to see if that played a role. They also looked at, the person performing the surgery also had an influence on the extent of the resection. So now you have these 2 cohorts, all of these variables. There's probably lots of confounding in there, and it's, you're thinking, how am I going to combine this? Well, luckily, statistics can do that for us. This was a very statistics-heavy paper, and to go through it, I definitely needed a little help. But once I touched up on my statistics, I broke it down into 3 steps that I think are a little bit easier to digest. So I'm going to share those 3 steps on how they broke down their data and the results they got to that. Right? So the first step here, or let me go back actually. Does anyone have any questions about how the study was broken or set up? All right. So here's the first piece of evidence that they looked at. So they wanted to make sure that if we take out more tumor, if we increase our extended resection, do we increase our overall survival? So they did this with something called a Kaplan-Meier curve. For those that don't know what a Kaplan-Meier curve is, what it does is it separates these different patient groups out, and then over time they see how many patients survive. And you're trying to get at, do patients live longer in certain groups based on certain interventions? So here, this top line, solid line, we can see our patients that had a total resection, 100%, and then at the bottom here are patients that had 50% resection or an 8 to 80% resection. Right, so you can see everyone started out alive, 100% here, and then as you go down, you start to see these separate, right, and that indicates that this top line with total resection means that if we increase the amount of tumor we take out, then we can increase our overall survival, right? So this just, again, more of a visual thing here. So say we at 24 months or 30 months, right, patients in this 100% resection group, 40% were still alive. Whereas in this subtotal resection group here, right, not all the tumors taken out, you can see less than 20% was alive. We were statistically significant, so that means that, yeah, if we take out more tumor, we have overall increased survival. Okay, so that's what they did in the first kind of step. Going forward, the authors use these terms gross total resection and subtotal resection, just to show that the 100% group is the gross total resection group. Everyone else is the subtotal resection group. Does anyone have any questions here? Any comments on what this data shows? All right. So we found out that if we take out more tumor, we increase our survival. So now they're going to get into the meat of this study, and that's if we use intraoperative MRI, can we increase the amount of tumor we take out? Right? So this top part here, this is this MRI analysis cohort, 286, where they have those specific details on the volume of the tumor. This is certainly interesting, but I'm not going to talk about that right now. I'm really going to talk about this red square, right, the percent of resection. So right away, you can see this is all the patients in the cohort, whether they got an intraoperative MRI or not. Then they broke this down again to patients where the surgeon was intending to take out all the tumor versus where the surgeon was intending not to take out all the tumor, whether it be like they can't access that specific tumor location or whatnot. But that's how they broke it down. So right off the bat, you can see when you use intraoperative MRI, we get on average more tumor out. Right? We get 98% of the tumor out with intraoperative MRI versus 94%, and that was statistically significant. So to answer the question right away, yes, if we use intraoperative MRI, we do increase the amount of tumor we take out. But that's kind of what we expected, and that's comforting that that's what we found. What I think is more interesting is if we look at this intended STR group, the subtotal resection. So the surgeons weren't planning to take out all the tumor. But if you look, they were able to get out 92% of the tumor on average here, versus if they did use the intraoperative MRI, they only got out 83%. And that difference is much larger than the group where they were planning to take out all the tumor. You see that difference? So that was statistically significant. So that means, maybe the intraoperative MRI gave the surgeon a little bit more confidence to, keep going and get more of the tumor. Another part that was interesting was this post-op GTR. So they just looked at the scans and they said after the MRI, whether you were intending to take out all the tumor or not, the surgeon was able to get out all the tumor. And you're able to see here that the surgeon was able to, in 11 cases, or 30% of the cases, they were able to take out all the tumor, even though they weren't planning to. Whereas if they didn't use the intraoperative MRI, they weren't able to get out all the tumor in any of the patients, right? And that was statistically significant. So that's, when I read this, it kind of provides some clinical information because it shows maybe this intraoperative MRI, maybe you don't need it for all the cases. Like this gross total resection, it looks like, when they're planning to take out all the tumor, it looks like they do a pretty good job of getting out all the tumor. But for those cases where they're a little hesitant to take out all the tumor for whatever reason, it looks like you're able to take out more tumor on average, and you might surprise yourself and take out all the tumor anyways, right? And then another point, the last point on this table I want to talk about is this missed accessible residual tumor. So you can think of this as on the post-op scans, they saw, hey, there was tumor still left that could have and should have been removed, right? So you can think of that as a missed tumor, right? And as you can see, everything here is nothing is statistically significant, but that doesn't mean it doesn't provide clinically significant information, right? So what it shows is when you use, there's no difference in misses, right? If you use intraoperative or non-intraoperative MRI, right? Do you see how that works out? So it's not like if you decide not to use intraoperative MRI, like if you're in this non-intraoperative MRI group, it's not like you're going to be hurting the patient by missing tumor, right? Because there's no difference between whether you use it or not. And I think that again gets to that point where, maybe for these patients where we know we're taking out all the tumor, looks like we don't really need an intraoperative MRI because we do a pretty good job of getting all the tumor. And it looks like there's no difference in whether we miss a tumor or not, right? Whereas in this intended subtotal resection, we're able to get more tumor out. So I think that this table provides quite a bit of meat to chew on for the clinical significance of using intraoperative MRI. Does anyone have any questions or any comments they want to add? All right. So we established that intraoperative MRI can increase the extent of our resection. And we know that increasing the extent of our resection can increase overall survival. So it just makes logical sense that using intraoperative MRI should increase our overall survival, right? So that's what they wanted to look at next. They did a univariate analysis and a multivariate analysis to answer this question. So this table here is the first one, the univariate analysis. I'll walk you through it. So you can see these are all the patients. You can see these general predictors we talked about earlier up here. These more direct predictors of the extent of the resection. And then these other variables, like that IDH mutant we talked about earlier, these other prognostic factors briefly mentioned, right? So these are just all the variables they wanted to look at. And they wanted to see whether it influenced the surgeon's decision to use the intraoperative MRI, right? The extent of the resection, and then the overall survival, right? And just for the sake of time, I'm just going to focus on this overall survival, right? Because that's why we're all here. So right off the bat, in the univariate analysis, the people in charge of stats, they work their magic, and they're able to make models where they're able to do their best to isolate a single variable, right? So we have all these variables, they're all occurring at the same time, but when we use that univariate analysis, we can do our best to just focus on the single variable of intraoperative MRI. And when you do that, you go over here to the overall survival. They report it in a hazard ratio. So that means if a hazard ratio decreases, we get less hazard, we get less death, so more overall survival. So we're looking at a hazard ratio that is less than 1. And what we find is when we use intraoperative MRI, we decrease our hazard ratio less than 1. So that means we increase our overall survival. And that's statistically significant. So right away, we know that the theory of if we take out more tumor, we survive better. If we use intraoperative MRI, we get more tumor out. So intraoperative MRI will increase our overall survival. Just considering the intraoperative MRI will increase our overall survival. So that's what this table shows here. And then when they did their multivariate analysis, they took these variables here that increase the survival. So the majority of these, right, going down, they took these variables here, and then they put that into their multivariate analysis on this table here. And what they do, we're still looking at a single variable, but it kind of takes all these other factors into account, right? And when we do this, we see that using the intraoperative MRI, our hazard ratio decreases, but it's not statistically significant, right? So when we look at intraoperative MRI by itself, we have increased survival. But when we look at it, intraoperative MRI, in light of all the other factors that patients present with, it's not statistically significant in improving overall survival, right? And that's what makes this paper interesting and something we'll talk about in the discussions. But before we go on, does anyone have any questions about this table or the previous table?
Mitch, I
Looks
think
like Ryan Blotz had a question in the chat.
Yep.
Okay, let me.
I can just read it to you.
Okay. I appreciate that.
Sure. He said, did they talk at all about the rate or amount of resection of healthy tissue in the cases in which all of the tumor is resected?
Are you getting at whether there was like a super maximal resection, like the amount of healthy tissue relative to tumor tissue? I think that's what the question's getting at.
I believe so.
So they did talk about that they did not use any supramaximal resection, and that was one of the limitations of the study. So they included, only included resections where it had 50% to 100% resection of the tumor. They didn't include anything that was lower, and I think specifically they didn't mention anything about the amount of normal tissue taken, but they certainly mentioned that there was no supramaximal resections. Yeah. I hope that answers your question, Ryan.
Thanks for that, Mitch.
Yeah. So let's get on to, this is just a kind of a summary of what we talked about, right? I'm starting to sound like a broken record, I imagine, right? Step one, we found take out more tumor, we get better survival. Intraoperative MRI allows us to take out more tumor, right? Just intraoperative MRI on its own improves survival. But when we consider everything else combined with intraoperative MRI, we don't get that improvement in survival. So that's the summary there. Before we get to conclusions, I want to talk about the limitations. So we already talked about this lack of supramaximal resection. The authors also note, and this is pretty obvious, that glioblastoma is multifactorial. That's why they did the multivariate analysis. But there's also lots of things we don't know about glioblastoma. Maybe there's other co-founders that aren't identified yet that they had no way to factor in. Potentially that is potentially explains the results we got. Additionally, whether the patients got intraoperative MRI or did not use the intraoperative MRI, that was not randomly allocated. It was up to the surgeon's discretion on whether they want to use it or not. And I think by definition, that is allocation bias. I don't know if that's a huge deal breaker, just because in the real world it is up to the surgeon's discretion whether they want to use the intraoperative MRI or not. So I think it replicates the clinical scenario. But if your goal was to have a more robust kind of association and a more clear association of intraoperative MRI on overall survival, that would be something you would have to adjust to get a better, a better conclusion, for lack of a better word. And then they did mention that they had incomplete data sets, and that's to be expected when you have to do a retrospective analysis, especially going back to 1996. So those are the limitations. Does anyone have any questions or any limitations that they think exist? No. All right, so I'm going to do the conclusion now. I'll save the discussion for at the end. That way we can have more of a big group discussion here. So the study itself supports the use of intraoperative MRI in glioblastoma resection. Like the theory behind it holds water, especially because the math supports it. But the study doesn't really identify the clinical significance, right? And that's just because that multivariable analysis didn't show an improvement in overall survival. It just highlights why glioblastoma is so challenging to treat. And they said going forward, they're going to need more studies to determine the true clinical impact that intraoperative MRI has. And of course, they're going to say further studies should have an increased case number, more complete data sets, better control of heterogeneity, really just to get more robust calculations, I guess. So that's the conclusions they had. And I think really kind of a take-home point that I got from this was I think they're going to have to differentiate a little bit more between whether they were trying to take out all the tumor, those intended GTR patients, versus the intended subtotal resection patients. I think if they maybe focus on that, you can see how we can go back to the table at the end. That one big meaty table we spent a lot of time talking about, we were able to see that the intraoperative MRI was able to take out quite a bit more tumor in those patients where they weren't planning to take out all the tumor. So maybe further studies focusing on that could kind of identify the true clinical impact. So now let's get into the discussion. So as far as the amount of tumor you're able to take out and overall survival, a discussion point we can talk about is glioblastoma resection clinically necessary? The author cited a 2011 study that said 78% resection is enough. Right? At that point, you get an improvement in overall survival. And they did mention that everything else above 78% still improves your overall survival, but they seem to hint at a kind of that theory of diminishing returns. At some point, we're chasing all the tumor cells and we're not improving our overall survival as much as we'd hope. Right? So that's a lot of where the controversy lies for the use of the intraoperative MRI. Everyone agrees, yeah, you get more tumor out and that's good, but is it worthwhile chasing all those tumor cells? Especially with evidence that says you only need to take out 78% to see results. And so that's another thing we can talk about. I already mentioned this, whether the patients were intended to have the whole tumor removed or whether they were intended to not have all the tumor removed. I think definitely focusing in on this, kind of these more challenging cases, it seems like the intraoperative MRI be more useful, just based on how I'm looking at the data. And then I'll just go through all the discussion points and then we'll open it up to everyone. So the cost effectiveness, you can imagine this is something we should consider as well. So a 2019 study looked into this and they factor in both the cost of obtaining the machine, the cost of using it, rating the radiology studies, prolonging the operation time. And they found that the intraoperative MRI increased the quality adjusted life years 0.18 more than non-intraoperative MRI, right? So that's about 2.5 months, I think, improvement, which is, I think significant, especially considering the mean survival is 15 months with glioblastoma. And the cost of that, they said, would be $76,442 per quality adjusted life year for intraoperative MRI. Is how they conclude the cost effectiveness. And that number doesn't really mean anything unless we compare it to what is cost effective. So generally, the cutoff in the past has been $50,000 per quality is considered cost effective. But now some studies are, or maybe it's half and half now, are transitioning to more of a $100,000 per quality cutoff as to what's cost effective or not. So this falls somewhere in between. So I think it'd be fair to say this is cost effective, but it probably depends on who's writing the paper. And then there's also something else to consider for cost effectiveness. Those dyes I showed you earlier, that glowed fluorescent, sorry, pink and green, those are also available. And they're cheaper to use. You certainly don't have to get an operating room ready for an intraoperative MRI. And they also mentioned you can also use ultrasound, intraoperative ultrasound to do a similar sort of task. But I'm not, admittedly not studied up on that. So does anyone have any comments, any discussion points they want to add?
I have a couple questions, but I'm going to wait to see if anyone else has questions first.
Yeah, I had a question really quick.
Sure.
I might just be completely off, but how accessible is the intraoperative MRI? Like, is it a common thing for most hospitals to have a portable MRI machine?
That's a great question. As far as intra, I don't know. I don't know. I don't know if it's common or not. I imagine hospitals that are, have better resources are more likely to have it. Kind of your, obviously, like lesser resources hospitals won't. But yeah, I'd have to look into that and get back to you. That's a great question.
Thanks.
Mitch, are you familiar with other modalities of intraoperative navigation?
Other than the dyes and the intraoperative ultrasound, no, I'm not.
Okay. That's okay. Did they mention? They did mention it's cheaper to use these other ways, but did they mention directly? For example, the ultrasound. I'm sorry, I might have missed this part. Did they say this is superior to the ultrasound?
So there was a study that they mentioned. I have to put it down here. Where did I put it? I think it was. I can't remember. It was in either 2016 or 2017, I think. But they didn't dive too much into what modality was more superior. They briefly mentioned one of the studies. I think it only had like 100 patients. Said there was a slight increase in the amount of tumor you're able to take out with intraoperative MRI versus the 5 ALA dye.
Okay.
But they said it was low quality evidence and that it was kind of a similar situation where it didn't influence the overall survival.
Okay.
Yeah. I'm missing, I wrote it down, but I can't really find it for you. Sorry about that.
No worries. I can't cite the studies off the top of my head, but I've read studies about intraoperative ultrasound and being able to resect more tumor than without it. So I'm just curious. It's not really something that you would have an answer to. I'm just curious as to the cost is much more effective for the intraoperative MRI, and so if it by itself isn't actually, improving the survival outcomes, if we're kind of just chasing the big shiny object, big shiny object syndrome, where it's a new fancy thing, but it may cost benefit may not be actually worth it.
Yeah, I think that's a good point. One of the 2016 study here, they cited how much, at the time, the qualities for the 5 ALA versus the fluorescein versus the intraoperative ultrasound, and then also the intraoperative MRI. So for the 5 ALA, they said it was $16,000 per quality. For the fluorescein was $3,000 per quality. For the intraoperative ultrasound was $6,000 per quality. And then they had different factors for calculating their quality, dollars per quality for the intraoperative MRI and this study, right, these numbers. But they said that the intraoperative MRI here was $32,000 per quality. So yeah, the intraoperative MRI was definitely cheaper. And if it's, that'd be interesting to look into whether one is superior over the other.
Awesome. Anybody else have a question?
Hey, Mitch. I have a question.
Sure.
First of all, really good talk. Glioblastoma is super interesting, and I've never heard of the intraoperative MRI, so this is really cool. Going off of the quality of life, I know you mentioned the cost, but and since more surgeons were able to get more of the tumor out than originally planned without the intraoperative MRI, did you see anything in your reading regarding like outcomes for quality of life? Like, did they have more deficits or recovery time?
The paper itself didn't address any of that. I didn't find any sources that directly identified that. And I think that gets at that kind of that controversy of here, right? Where, yes, we see, all the data shows that you get more out and that's overall survival. But that doesn't factor in kind of the patient's experience or the kind of those other clinical effects that we should definitely consider. But the data just, at this point doesn't have any way to show us. So I think that's what they're trying to hint at by saying we need to find more kind of clinically relevant data points to look at. But that is a good point because you would definitely want to consider those things.
Thanks.
Thank you. Yeah, I think that gets a little bit at, let me get back to that Kaplan-Meier curve, right? Because you can see here, they're a little jumbled up here, and it takes a little bit of time before things separate out, right? So you say maybe here is when lines start to separate out, and we start to see an effect. That's about, maybe a little bit past 15 months, and at 15 months, everyone's more or less the same. So yeah, factoring in the overall clinical outcomes for the patients during the operation to the 15 months, right, is something we would definitely want to consider because, yeah, the median survival for glioblastoma is 15 months. So, yeah, that's a great point.
I have another question, Mitch.
Sure.
So you mentioned they took into account the actual surgeon conducting the procedure. Was this this was at the single institution part of the study, correct?
Yes. Yeah.
Okay, so that's that's a limitation to identify there. Did they discuss the way they broke down, like how they, I guess, stratified the surgeons based on experience or based on?
So that's another good question. They really didn't talk about kind of their procedure for identifying which surgeons have essentially. Well, I guess they were looking at which surgeons take out more tumor. They didn't really identify any sort of protocol they used to do that. They really only mentioned that briefly, and I think it's just because it came up statistically significant, a variable that was statistically significant, so they felt it was important to report it. But they didn't go into any detail on exactly how they assess that.
Okay, that's what I thought. Trying to remember back to when I looked through this, I'd be interested to see in the future, a more detailed analysis of the effect of the surgeon and the surgeon's experience, on this data, because I feel like that's probably heavily influences the outcomes.
Yeah, I think so. Maybe part of it too is I would imagine the intraoperative MRI certainly takes a much longer time than the non-intraoperative MRI. And if you're a more experienced surgeon, maybe you can get it, maybe you're more likely to do it because you're more efficient. You can get things done faster, whereas you're less experienced. Maybe things take too long and eventually you just don't have time to do all these things. So yeah, that's a really good point.
Other questions?
I actually have one more, Mitch.
Oh, sure.
Did you see anything about, or was there anything about the different stage of the glioblastoma at the time of surgery? I didn't know if that could influence any of the results that we've seen or not.
So they didn't mention anything about the stage. So they were all grade 4, but they didn't mention anything about the stage. I think their estimate was that ASA, I think, was a kind of a surrogate for that KPS score, kind of like the patient's patient's well-being. And I think that was kind of their best kind of, I guess, surrogate for how progressed the patient was. But no, they didn't mention anything specifically about the stage.
Okay, thank you. That's helpful.
So these are the take-home points. I imagine people have been reading those when we were talking about questions. or comments. So let me stop sharing my screen so I can see everyone. All right. So it looks like good.
I do have one other thing here, Mitchell. Sorry.
Sure.
I was just looking at the ASA classification, and it looks like it doesn't include functional status.
Oh, really? Okay.
So I think, I guess not really much of a, well, I guess it's a question too. I'm assuming, did they mention anything about the patient's functional status? This kind of piggybacks off of Gretchen's question, going beyond the financial aspects of the quality of life, actually looking at the functional level of quality of life. The ASA score, it seems not to include that. So, if there's negative outcomes or paralysis or those type of things, you might be able to increase survival, but and in some ways maybe even somehow increase costs, but not necessarily impact functional status. So I guess more of identifying another limitation of the study. A lot of studies I see on these topics include functional status. So
thanks for looking into that. They definitely they didn't officially list that as a limitation, other than just really saying like, we wish we would have had the KPS scores, but great point.
Awesome. Any other questions, guys? All right. Well, Mitchell,